Basically, I think it's actually quite relevant to our setting because after we graduate as a medical student and houseman, then become MO, actually no one actually taught us about how to interpret the MRI, especially the brain, which is important in neurology interpretation. So we're just going to go through a bit of basic, then we go through the approach. Subsequently, we will see various examples, go through various cases. Hope that everyone can learn something from this session, okay? All right, so our outline will be like this, okay? So we'll talk about approach, then the second session is about a short quiz. So I hope more people can join as the time goes. So in terms of approach, I will talk a little bit on the anatomy and a bit of principles and what are the sequences that commonly used in MRI. And then I'll talk about the bright versus the dark. And subsequently, I will conclude by comparing these various types of enhancement, and hopefully we compare sequence by sequence, okay? So this is our basic approach to MRI. First of all, we need to identify a few things, okay? We need to identify a patient identity, patient name, ICs, and then whether we are looking at the correct patient. And then we need to correlate with the clinical history as well as the examination, because history and examination, like we learned in the past, is 80% of the diagnosis most of the time. And investigation is a tool to actually guide us to come to our diagnosis, provisional diagnosis. So history is very important before we interpret any MRI. And the next thing to identify is what plane are we looking at? Is it an axial view, or is it a sagittal view, or is it something like coronal view or something else? Okay. Then the third thing in identification is actually to look at the sequence. Okay, there are a lot of sequences that we're going to go through later on, but those are the basic sequence that we tend to compare in order to get a pattern and to confirm our working diagnosis. So we also need to identify the anatomy, what is normal and what is abnormal, okay? So after we identify these few things, we'll go through, analyze the brain, in particular, whether there's any asymmetry, any midline shift, any asymmetry in the sense of we look at the midline and then we compare for structure from above to below. Subsequently, we'll compare the intensity, like I say, bright versus the dark, okay? Then talk about enhancement pattern and we compare the sequences. Then we finally came out to a diagnosis. Okay, so under the identification, like I mentioned just now, as you can see in the photo here, the first photo, as you cut the head longitudinally like this, you'll get the axial view. And if you cut the head back and behind, you will get a coronal view. And if you cut from left to right or side by side, then you will get a sagittal view. But today we're just going to focus on axial view, predominantly axial view, because this is going to be the one that we commonly see. And so we are going to a few, I will divide the anatomy part into a few cross sections because this will facilitate us to understand some normal brain anatomy structure in our body. So this is the axial cut through the superior frontal parietal region. As you can see the photo here, it's actually superior parietal. Okay, so this is the CT brain plane and this is the MRI, okay? So what we can see here, usually the basic of reading a brain, whether it's MRI or CT brain is, we have to identify the normal structure. So you can see the yellow highlighted structure here. It's actually called omega sign. Why is it called omega sign? Because it looks like an omega. This is actually the precentral gyrus, okay? So this precentral gyrus and in between is the central sulcus. So this will actually differentiate two things. First thing is, anterior to this omega sign is the frontal lobe. Posterior to this omega sign is your parietal lobe. Okay. Second thing is, immediately at the omega sign, say it's actually the precentral gyrus, which is our motor cortex. Okay. Then posterior to this is actually postcentral gyrus, which is actually sensory cortex. So this is actually important for us to identify the normal anatomy and normal structure. And same goes to MRI. As you can see, the omega sign is here, and this one is here. Okay. So if you want to get a clear detailed history, then we can ask our Netter, the very famous anatomist, as well as the artist. So he actually do that. So you can actually compare side by side like this, from CT brain to MRI to the illustration as above. Okay. So the next brain is actually ganglionic part. through the basal ganglia. This is very important for us, especially for CT brain in terms of stroke identification for expect score calculation. But in our particular focus or interest today is more to a general structure, general anatomy, not only limited to stroke per se, but you can see here, I will use the CT brain because this is the one that we are most familiar with. So here is actually the head of cardiac, okay? And then as you see, there's an internal capsule, anterior limb, followed by general and posterior limb of internal capsule. Subsequently, posterior to that is actually the thalamus. And then laterally, this is the lentiform nucleus constituted by the globus pallidus as well as the putamen. Then lateral to that is actually this is what we call as insular cortex, okay? Immediately after the insular cortex is the medial, is the anterior temporal loop, okay? So you can see here, the MRI gives a better picture, but you can also identify this structure under the CT scan. So to compare with the natural diagram, it's almost similar. Here, cortex is here, internal capsule, thalamus, lentiform nucleus, insular cortex, and then anterior temporal loop, okay? So this is the second cut, which is the commonest cut that we actually look at, the basal ganglia cut. So the third cut is actually Schonfeld fissure, sorry. So this is Schonfeld fissure, you can see here, this lies our middle cerebral artery, okay? Sometimes in the acute stroke, in the normal CT scan, we will see a dense NCA sign, okay, as compared to the contralateral side. Okay, so this is the CT scan. But you can see here, CT scan, everything towards the posterior and the central is very blurred. You cannot really appreciate any other structure. But compared to MRI, you can actually see that, oh, there's a lot of structure that you can visualize. For example, I will just give an example. When we talk about basal meninges, when we talk about basal meninges, it mainly constitutes two things, okay? First is actually the so-called subarynoid system, and second component is the quadrigeminal system. You can see the subarynoid system is actually constituted by a six-pointed star. So the first pointed star is actually interhemispheric fissure, or it forms a cistern. Cistern is basically a reservoir. It's any space that in the subarynoid space that contains CSF is called cistern. Okay, so you can call it as a cistern. Interhemispheric cistern is a first pointed end, and followed by the lateral two ends, which is the Schonfeld fissure, or you can say Schonfeld cistern as well. And then posterior to that, there is also here, it's called ambient cistern at the both sides. So we got like 1, 2, 3, 4, and the, okay, 5, sorry. And then the fourth and the final sixth one is actually the interpeduncular cistern. Okay, so this will form a star shape. Okay, so if let's say there is any form of subarynoid bleed, we can see in CT scan you will light out. But for MRI per se, I will go into the bleed in a later part. But for MRI per se, we are basically more concerned about meningitis. So you will see lateral meningeal enhancement at the basal cistern. So continuation from the subarynoid cistern, from the ambient cistern here, it will combine with the quadrigeminal cistern. So all these will form something we call a basal cistern. Okay, so you can compare the natural illustration at the right side, which is almost the same, but it's just to delineate the anatomy further. So the fourth cut is actually at the midbrain level. So we know that brainstem got midbrain pons as well as medulla. Okay, so for midbrain level, as you can see, CT brain actually is very limited view, but we still can see the midbrain. Okay, and there's also basal cistern as you can see here. And if you can compare the anatomy, basically at the level of the midbrain, you should be able to see past the Schonfeld fissure. That means it's slightly below the Schonfeld fissure, and then you can sometimes appreciate something else, some structure, if you give contrast, things like that. But this is basically this is a T1 view, so you can only see the basic anatomy. Okay, so proceeding further, this is the level of the pons. As you can see, at the level of pons in CT scan, we always can see the fourth ventricle, and then we will compare whether the fourth ventricle is actually enlarged or not. Okay, so because enlarged and not enlarged, whether fourth ventricle is enlarged or not enlarged will determine whether if the ventricles, lateral ventricles, the ventricles are dilated, it's going to be decided whether is communicating or non-communicating hydrocephalus. Okay, so in MRI, as you can see the inferior part of temporal loop more clearer compared to the CT scan plane. And this is the comparison. You can see the cerebellum here. You can see fourth ventricle, pons is somewhere here, and this is what we call as cerebropontine angle, because pons is actually at the front, cerebellum is actually at the behind. So in between this angle is a very narrow angle called CPA angle. It's a CP angle. Okay. So next cut is actually at the medulla. Okay, medulla, as you can see, most of the structure you can see compared to natural one. Basically, we want to look more to the sinus, like ammoid sinus, things like that. But you want to see whether the medulla any lesion, and then at the same time you compare the cerebellum, and basically that's all. So the last slide, this is the foramen magnum, and under the inside the foramen is actually our, you can see the cervical cord. Okay, it's very small here, but usually you can see the cervical cord. Whether there's any, usually if let's say a very upper cervical compression, sometimes you might be able to see. Okay, so basically, okay, I already go through all the basic level of the plane that we usually see. Now I'm going to go through a bit of basic for MRI. So I'm not trying to promote a car here, but basically Tesla is actually a unit. Okay, it's a unit to suggest a strength of a magnetic field. So how many Tesla, it actually means that how strong the magnetic field are. So basically in our conventional MRI setting, we only got 1.5 and 3 Tesla. Okay, the more higher the Tesla is, the more detailed anatomy you can see. In the overseas, international setting, there are researchers that actually use up to 10.5 Tesla. Actually, even until now, 17 Tesla, 22 Tesla also available, but those are mainly for animal study. The more Tesla, meaning more strong the magnetic field is, it basically means that there is a risk. We don't know, because human trial never go beyond 10.5. So there's also a risk of, in terms of causing a lot of magnetization to the tissue, and then affecting the polarity, things like that. So usually in the research, use up to 10.5, but in our setting, we only use 1.5 to 3. 3 Tesla is important. I think Dr. Shuganti will always order 3 Tesla for those patients sometimes want to see, to localize the epileptic foci. You know, we want to plan for the epileptic surgery, then we need to go for 3 Tesla. Okay, so basically, the stronger the magnetic field, it means that the higher signal to noise ratio. Okay, I will come to this later on, what you mean by signal and what you mean by noise. Basically, it's just like you want to create a high resolution image, but sometimes a lot of interference, okay, because a lot of things also emitting magnetic field, things like that. So if you're actually interfering, causing the image become blurred. So that's why a lot of noise there. But if you have a stronger magnetic field, you can actually suppress all the other magnetic fields caused by various objects. So that's the reason why there's a high signal to noise ratio, and this will lead to better resolution. And if you want to stick at the same resolution, you actually make it faster to be done. The MRI can be done in a shorter time compared to the conventional one. Okay, so this is the basic principle. So now I go to 3 main principles that how MRI actually works. As you can see in the diagram here, this is the hydrogen atom actually oscillating at its own frequency, or what we term as Larmor frequency. Larmor frequency is actually, there's a formula to calculate it, but we are not physicists. We are not into physics. So this is just nice to know. But basically, every atom in the body, our body mainly made out of water. So inside the water, hydrogen atom actually constituted by H2O, which is our hydrogen. So this is actually constituted by the positive charge, the proton. So each atom actually have its own frequency, oscillating at different times and rotating and free-flowing around our body at a different frequency. So in order to generate a good MRI image, we need 3 things. Okay, we need to align them, and we need to give them energy, or what we term as excitation. And subsequently, we need to let it relax, okay, and emit out the energy that we have given the atom. So alignment, a good analogy of how we know, how we learn about this MRI principle is, imagine when there's a lot of children in the primary school, they are actually waiting for a general assembly, okay? Then suddenly a headmaster come in, and then just about to start to say something, because the headmaster got own aura, a so-called magnetic field. When as the headmaster walk in front of the stage, everyone will straight away align perfectly in the straight line, row by row, column by column. This is what we know as alignment. So in MRI, it's the same thing. In alignment, we actually induce a magnetic field, a similar magnetic field to all of the atoms inside our body. and it will align in parallel together, and then they'll form a same line, a straight line, parallel line that never actually intersect. Okay, but the problem with this alignment is, although they are actually queuing up one by one, but they are actually some, for example, some students might still be talking to each other, and talking about different topics, things like that. So until the point that headmaster actually say out something, okay, please keep silent, things like that. So he actually exerted something they call a radio frequency energy. You need something called radio frequency energy to actually to make sure everything is in sync or in phase. As you can see here, our atom is actually initially out of phase. Okay, this is okay. We just wait for a while for the photo to actually move. So initially it's out of phase. Then we give radio frequency energy. Then you will change the axis of the atom, and then they will be in phase. So this is what we call as excitation. So why does it matter? Why we need to know about this is because our MRI is actually is good at detecting the relaxation phase, which means the atom, after they excite, they are in phase together, and then only when they start to release the radio frequency energy, only then we can actually analyze the different amplitude and different phase of the atom in order to come up with the image. So relaxation actually got two phases. Okay, it's actually either T1 or T2 relaxation. It seems complicated, but actually it's actually quite simple. So for T1 relaxation basically means how long the atom actually takes to actually return back to its original position. So we will say that the cut point will be like at least 2/3 of the atom actually came back from y-axis, go back to their z-axis. Okay, this is termed as T1 relaxation. Okay, so in T1 relaxation, okay, you will see that it's actually more to longitudinal magnitude. Those magnitude and then those 3D longitudinal transverse things like that is not important for us, but you just need to know that because we are actually measuring this relaxation, that's why the fat, I mean something solid compared to a water or a liquid, will actually be different. A fat will actually relax faster compared to water. So that's why in T1 relaxation, our T1 MRI sequence is actually measuring the T1 relaxation time for our cell tissue, our tissue in our body, regardless of where is it. So if let's say the fat actually relax faster than water, it explains why our fat will appear bright in T1 compared to water. Water will actually appear dark because it's actually delayed, slow compared to tissue, things like that. So it explains a lot when we go back to our basic to understand the basic. So the next thing is actually T2 relaxation. There's two phases. One is actually to actually the atom will relax back to its original position. T2 is about measuring the time for spinning proton to actually dephase. Dephase meaning it might not go at one direction only, it can go to other direction. So T2 is actually measuring this kind of direction. So this thing actually something, if you learn about the MRI basic, there's something called TE and there's something called TG. Basically it's like echo or repetition time. Okay, so basically in T2, you're actually measuring the phase of the atom when after the relaxation take place. So as you can see, water actually slightly slower compared to the fat. Fat is still faster, but in this phase, as you are actually measuring the oscillation and the echo. The more echo it is, the more bright the MRI can detect. So it means that the slower the relaxation time, the brighter the substance will be. So that's explain why fat is actually slightly dark in T2 sequence as compared to water, which is going to be bright because it's just like you are using liquid paper to liquid again and again and again, so it becomes brighter and brighter and brighter. Okay, so that's the principle of T1 and T2. So I will straight away go into sequence overview. So MRI at one glance can be difficult and can be complicated, but actually it all goes down to the basic. So when we talk about sequence, there's a lot of sequence that we need to look at, but there's only a few important ones that we need to really understand in order for us to interpret the basic pathology. So we can classify it as T1, T2, diffusion rate, flow sensitive, and the rest is others. T1 is basically a traditional conventional T1 that we talk about, and you can add a contrast into T1, we term it as the T1 gadolinium, post-gadolinium. And at times, because as you know, as we discussed earlier, the T1, under the T1, fat will become bright. Sometimes too much things that's bright under the MRI will actually interfere our interpretation. So that's why you can actually suppress the fat as well if you want to. So for T2 is the conventional T2. You can actually modify the T2. Then you create something called flare, free attenuated inversion recovery. I will talk about this later. And you can also modify the T2 by actually measuring how much the atom is susceptible to the magnetic field. This is something called susceptibility weight imaging, or GRE, gradient echo. Okay. The third category is diffusion weight. Diffusion weight is a so-called shock protocol. It's our most sensitive to detect acute ischemic stroke. I will come to later on. I will talk about this. But basically, DWI, if you want to look at DWI, you cannot just look at DWI. You need to compare with ADC. Okay. So these are the things that I'm going to talk about. The rest is not so important as a basic, like flow sensitive can be MRA, MRV, CSF flow study. Other things like MRS, MRP, functional, those are slightly popular and least useful. Okay, so this is just an illustration of normal MRI sequence. As you can see, this is a T1, and then you got T2. From T2, you can derive to flare. Basically, you just same as T2, but you remove the CSF free, which is the water, and then you appears dark. Okay, and then you got T1 post gado, and then under the T2, you can also derive the gradient echo sequence. And for the diffusion weight, you can also have DWI and ADC. These are all the common MRI sequence that we need to know. It sounds a lot, but actually, when you understand the basic behind it, it's actually simple. It's not so complicated. Okay, so we'll go to T1 and T2. As I mentioned just now, fat and also CSF, which is the water. You already know that under T1, the fat, as you can see here, will become bright. Okay, there's a few fat components surrounding after the skull, outside the skull, and then which will going to appear dark in T2. Okay, how about water, which is the CSF? Okay, you can see that CSF is actually appears dark in T1, which makes sense after we understand the basic behind T1 and T2 relaxation. And then under T2, the CSF is going to appear bright because of repetitive time is increased, and then there's also increasing echo time. There's also TE and also TR, which is not so important to remember, but just need to remember the basic behind it. So another thing to remember is T1 and T2, you want to identify which sequence is actually T1, which sequence is T2, you need to look at two things. Okay, T1 is also known as anatomical sequence because gray matter will appear gray, white matter will appear bright white, which means white will actually become white, gray will become gray. So you can see the gray matter outside is actually gray, and inside is the white matter, it appears white. As compared to T2, you see the outside, our gray matter will actually still gray, but our white matter will appears to be dark. So that's the first clue to actually differentiate between T1 and T2. And second thing is, of course, look at the CSF. But CSF is not a very good way to actually differentiate whether this is truly T1 or this is something else, because I will go to later on, because in flare, which exactly the same as T2, but we remove the water, we remove the CSF. So that's why it appears as if you are looking at T1. But if you look at the gray-white differentiation, the gray matter will actually gray, but white matter will actually appear dark in the flare, because flare is everything same as T2, but we actually use something to actually remove the water. Okay, so I will straight away go to flare. It's basically, like I say, derived from T2, and what we do in flare sequences, we will nullify the signals by choosing a specific inversion time. As you can see here, this is actually T1 because gray will appear gray, white will appear white. Okay, and the CSF here is actually dark. Okay, and this is T2 because we know that the gray matter still appears gray, but white matter is actually dark. Okay, and you can see the CSF is actually clear, bright. So this is T2. So flare, as you can see here, is very similar, is exactly same image as T2, but because we choose a specific time, we will negate the water component. which means MRI doesn't actually detect the CSF flow, which will appear dark, as you can see here. And this is easily confused with T1 if you didn't look at the gray and white matter properties and the intensity. Okay, so why do you want to use flare? Flare is actually very good in terms of delineating gray-white lesion as well as a periventricular lesion. As you can see, this is a flare sequence. You can see here the cortical gray matter, the lining is very clear, okay? And then the subcortical white matter is going to be appears dark, and then it's also very clear. You can also see a subcortical gray matter as well. So you can see the structure very well, and this is very actually useful for us to detect a lesion in the brain sometimes when we cannot actually appreciate under the T1 or T2, okay? So the next sequence I'm going to talk about is actually DWI. So DWI is also known as the stroke sequence, okay? So the principle behind this DWI is actually measuring the Brownian movement, the random movement of the water protons, okay? Because as we know, H2O is basically hydrogen and oxygen. So we are actually measuring the random movement of water across the tissue. So if you compare the basic principle, if the water is inside the cell, which is intracellular, that means there's not much of a water diffusion going on because it's a confined space. But if you measure the diffusion of the water across the extracellular space, which is going to be very large and water can move more freely, so there's no restriction in terms of diffusion. The more restricted the diffusion is, the brighter the image will fall under the DWI. So, which makes sense. Why does it very sensitive to detect acute ischemic stroke? Because in acute ischemic stroke, because of the hypoxia and cells start to die off, and because cells start to die off, the sodium potassium ATPase actually lost the function. So the sodium will no longer, pump out and potassium will no longer pump in, which means the sodium will going to be retained in the cell. And what happens when sodium retained in the cell? The water outside the extracellular fluid will actually come in because of the concentration gradient. Water always follows sodium. So that's the reason why the cell will swell up. As the cell swell up, it's actually called cytotoxic edema. So as the cell swell out, as you can see, if you measure that particular cell that is actually swollen, you can see all the diffusion is actually restricted, which means patient will actually, under the DWI sequence, this particular region is going to appear bright because all the diffusion inside is actually restricted as compared to the outside. So in other scenario, a brain tissue that have a high cellularity, for example, lymphoma or abscess, is going to appear bright as well. And if let's say there's any presence of any larger molecule per se, it's going to appear bright. But all the remaining two is not so important. The first importance of the DWI is to detect cytotoxic edema. Okay, so as we talk about DWI, it's also important for us to know about his evil twin, which is called ADC. Okay, ADC is a known, in informal way, is an anti-DWI sequence. Okay, what is the importance of the ADC? It's basically to detect and to confirm whether the diffusion, the bright intensity, hyper intensity that we detect under the DWI is really true diffusion restriction, or is just a defect, an artifact because of T2 sequence. Because we know that T2 is the DWI and ADC is going to derive also on the T2 image, and sometimes the image in T2 can appear bright, and then DWI will also appear bright. But it doesn't mean that the bright under the DWI is diffusion restriction. Okay, so how we compare? I got a simple algorithm here. As you can see, if let's say we see anything bright in DWI, we have to think that there is a diffusion restriction. And how do we confirm it? ADC is going to appear totally opposite if let's say there's a true diffusion restriction. So ADC is going to be appear dark like this. So with this, you are quite sure then this is true diffusion restriction. And if let's say DW is dark and ADC is bright, which means that there's no restriction in terms of diffusion. In fact, it's increased compared to the surrounding structure. Okay, and how about when you look at DWI? which is going to be hyper intense, and ADC also bright. So it means that this is not a true diffusion restriction, but instead this is something we call T2 shine through, which is commonly seen in acute demyelinating disease. I remember Dr. Shanti V taught us about this. You can see DWI is bright, ADC also bright. Then you need to suspect MS, the lesion. So we'll go to example. So this is a patient presented with a 2 hours history of 2-hour history of left-sided body weakness. So because of stroke activation in a tertiary setting, not in our setting, they did a MRI stroke protocol. So you can see here, as you can see here, this is DW, the left here is actually DWI, and this is ADC. So DWI confirmed that there is hyperintensity, which means there is a diffusion restriction suggesting of cytotoxic edema. And you confirm with the ADC, which is going to be totally opposite. And there is no abnormal so-called T2 shine through because everything bright is appear dark over the ADC. So if DWI appears bright, that means this is something we call penumbra. Okay, and we compare the flare sequence. If let's say the flare sequence is normal, then which means that this infarct is not established yet. It's just penumbra. There's no core yet, because flare can detect core and DWI can detect penumbra. So in this case, this is a DWI flare mismatch, which suggests that this is a hyperacute right MCA territory infarct. Okay, so it's actually a clear-cut method to actually, as we come down to stroke protocol, using the MRI, okay, we will know that if let's say the flare is actually also hyper intense and DWI also hyper intense, which means that there is already established core and infarct. It already infarcted, okay. So the next example is this, okay. You can see here, this is same, this is DWI and this is ADC. So in DWI, it appears bright. There's a focal central diffusion restriction, possible diffusion restriction. We compare with our ADC, which is totally inverted. There's no abnormal bright signal that we can see in ADC. So we know that there is a diffusion restriction. And like I say, there is also most likely because of this, as you can see, there's a surrounding finger-like projection. Most likely is some form of vasogenic edema is going on, which is going to be dark under DWI because there's no diffusion restriction. In fact, there's increase in terms of diffusion. So vasogenic edema will appear like this. It will appear dark in DWI and white in ADC, as opposed to cytotoxic edema. Okay, this is what we know as most likely is a right cerebral abscess with vasogenic edema. Okay, so how to know that this is another example. So if this is a DWI and this is a flare sequence, as you can see, flare there's a hyper intensity and DWI also hyper intensity. So you want to confirm whether this is true diffusion restriction, you look at ADC. So what happened in ADC? ADC is also bright. So if ADC is bright and DWI is also bright, then you know that this is just T2 shine through because of the T2 of flare sequence hyperintensity. This is not a true diffusion restriction. Okay. So now we will go to something a bit more advanced. I mean, just to because we are all in neurology posting, and then I found it relevant because recently a lot of patients with tumor factor demyelination, and then I figured out that probably this is a good time to actually discuss about this. Okay, so in tumor factor demyelination, we always want to actually differentiate between, is it a true tumor or this is just tumor factor demyelination? It's because the demyelination is so huge that it behaves and appears as if it's a tumor. Okay, so as you can see in here, this is a T2 flare sequence. Okay, and this is a sagittal T2 flare. Both are actually T2 flare. Okay, so and there is a bit of midline shift as you can see here. Okay, so from this view alone, we cannot really tell whether this is tumor factor demyelination or tumor. So we need to compare a series of sequence. Okay, so introducing back what we just learned, which is our DWI and ADC sequence. So this is DWI and this is ADC. So as you can see here, the central area, which is going to be so-called the tumor area, this central portion appears dark under DWI and bright under ADC, which means that there's no diffusion restriction. Why? Because in a diffusion restriction, in a true diffusion restriction, then it should be hyper intense in DWI and become dark in ADC, but this is totally the opposite. So we can surely say that there's no central diffusion restriction. Okay, and how about another modality which I'm not going to talk about in detail, but I'm just going to introduce for everyone to know. Okay, this is the MR spectroscopy for the same patient, and I'm just going to put, this is the right side. Over the right here is the our normal human MRI should look at, and over the left here is the patient MRI sequence. Okay, as you can see here, there's a few spiky things that we actually measure. In NAA is what we term as N-acetyl aspartate. But you need to know the full name. NAA is basically will be present if the brain tissue is healthy. So if you put any probe towards any healthy cell, you will see this NAA spike, which is a sign that the brain is healthy, is filled with healthy cell. Okay, and you got creatinine, you got choline. Okay, and you can see that creatinine is usually higher than choline. Creatinine usually suggests that there is a metabolism, and choline usually suggests that whether there's any turnover of the cell. So in this patient, it's totally opposite. What you can see in the most striking feature is this NAA and this NAA is so reduced. Okay, as they put the probe over here, somewhere in the center, the NAA is so reduced, which means that there's not much of healthy brain cell there. Okay, that means cell is already died. Okay, and you can see that, as I mentioned to you just now, the creatinine and choline, there's inversion in terms of the ratio, because here the creatinine is actually lower compared to choline. This inversion of this choline to creatinine ratio suggests that there's increased metabolic rate. So in summary, what we can appreciate is that there is high metabolic activity with neuronal loss or loss of the brain tissue. We don't know what is that. Is this MR spectroscopy useful? The answer is not helpful, because it doesn't actually help us to differentiate whether this is tumor factor demyelination or tumor. I quote this actually after I asked Dr. Nozaini. Dr. Nozaini is the one that told me this is no longer used. This is the 30 to 40 years of the technology that doesn't actually help us at all, because in tumor factor demyelination and in tumor, both you can see both pictures is almost the same. You cannot actually differentiate them. And this is the time that we actually need something extra or some extra tool to actually help us to differentiate. So just forget about MRS. This is something for academic purpose, and then for everyone, good to know, okay? But the real thing, the real gist behind how we differentiate tumor factor demyelination and tumor is, we look at the pattern, okay? We look at whether the enhancement, whether it's a ring, is a complete or incomplete ring enhancement. If it's a more to incomplete ring enhancement, it's more to tumor factor demyelination. And in tumor factor demyelination, it's more to mixed and hyper intensity as compared to tumor. But this is not very sensitive, because tumor can also behave this way. And usually, another clue to actually suggest tumor factor demyelination is, look at how big this lesion is. With such a big lesion, if it's a tumor, and usually the vasogenic edema is going to be very profound, and therefore the midline shift is going to be very bad. But in this MRI scan, there is a bit of midline shift, but it's not so marked as out of proportion to the degree of the lesion. So in tumor factor demyelination, usually there is a minimal or there's no mass effect. Okay, it's more to inflammation per se. There's not much of the pushing and also the mass effect. So, and in tumor factor demyelination, usually there's no cortical involvement. So these are the few clues that will actually give us a bit of idea whether this is more to tumor factor demyelination or tumor. For MRS, there's also another thing to look at the glutamine and glutamine peak, which I'm not going to discuss, because actually the subsequent studies and the latest research says that MRS is no longer specific nor sensitive to actually detect and differentiate. Okay, so after we talk about T1, we talk about T2, we talk about flare, we talk about ADC and also DWI. Now comes to the second last, which is the GRE, gradient echo. I remember Dr. Prasad, I think he's not around. Okay, Dr. Prasad actually taught me this sequence when I was like day 2 in neurology rotation. So he showed me one of the patient MRI, and he told me, if you look at this GRE sequence, you mainly look at two things. It's either blood or calcium, okay? Which is still holds true, because every time when I look at GRE, if you can see anything dark, any black spot inside the gradient echo, it means that there is a bleed. And it's true enough, after further study, things like that, we know that why it's severe dark is because, back to the basic principle that we learned before, The MRI is actually means to use magnetic field to align the atom, subsequently exert a radio frequency energy to make it in phase, make it everything be same. Only then the atom will release the energy back to the surrounding, or what we call as relaxation. But in a certain circumstances, for example, blood which contains iron, and a certain artifacts, a certain deposition of the metal, for example, copper, be it a copper or iron, those is going to have their own magnetic properties. And this magnetic properties is like a black hole in the universe. It's going to eat out the surrounding magnetic field which exerted by the MRI machine. So therefore, it will appear dark. So this is something called as blooming artifacts. So in GRE, if you can find there's any black spot in GRE, you need to look hard for whether there's any bleed and whether there's any deposition of the metal. Okay. So in this patient, you can see there's diffuse, periventricular, and also subcortical involved hypointensity under the GRE sequence. This is most likely to be CAA, okay, because of microbleeds, cerebral amyloid angiopathy. I think we will have a CME on this at the end of the month by my colleague. So the last sequence that I'm going to discuss is actually T1 gadolinium, post-gadolinium phase. So same as the CT scan. CT scan, we have a CT plane, and then we inject contrast, and we have CCT. But in MRI, our contrast is known as gadolinium, okay? So we call it as T1 GAD or GAD phase, okay? Gadolinium is basically a medium to actually reduce the relaxation time of proton, which means that if an object, because we're going to inject the gadolinium into the blood circulation, and circulation is going to flow through our CSF, our cerebral blood, and then anything if let's say the blood can pass through, can flow through, it will appear bright because it will actually reduce the relaxation of the atom at a particular point of time. So gadolinium phase is actually very useful for us to detect any extra-axial or intra-axial mass, as well as whether there's any anomalies in terms of the vessel. As you can see here in T1, and this is on the left here is actually T1, MRI T1 sequence. You can see something is there, okay? There's a loss of some normal gyri and south side arrangement, but you're not very sure. So you actually look the T1 post-gadolinium sequence. As you can see here, this is very obvious because you can see a lesion here. Because it's enhanced with gadolinium, you will know that this is most likely is extra-axial because it doesn't involve any cortical tissue. And there is some form of durotail here. So most likely this is meningioma. Okay, just based on the gadolinium sequence, can be very helpful for us to diagnose. And this is the different cuts of a normal MRI brain. So you can see this is the Sylvian cut, this is the ganglionic view at the basal ganglia, and this is the superior interparietal cut. So if you want to light up with gadolinium, a lot of things is going to appear bright. So what we usually do is, under the MRI, this is by the radiographer, usually what they do is they will suppress the fat tissue, which means you can see in our orbit here, there's muscle and there's a fat in the extraocular muscle. So if you suppress the fat, the bright will become dark. And you add on the contrast, which is the gadolinium to it. So it will become like this. As you can see, the orbit here is going to be dark because you already suppressed the fat. Okay, fat cannot be seen here. And after you given the contrast, you can see that all the vascular territory lights out, be it a vein or an artery. So you can see a normal contour of the contrast post gadolinium from superior sagittal sinus to a deep draining vein, as well as you can see the transverse sinus and also the MCA, PCA territory. So it can help us, very helpful for us to detect any vessel anomalies. And based on this, usually it can actually reconstruct with a 3D view to look at the vessel to study more detail about anatomy, which is not going to be discussed here. So this is the normal T1 post-gadolinium view. So at the end of the day, we need to know the normal anatomy of the brain, then subsequently we need to identify what is abnormal under the MRI brain. So MRI brain can be hyper-intense or hypo-intense if let's say the lesion is abnormal. So we need to know, it may look like this, you need to memorize all this, but actually a lot of things will make sense, okay? As we go through a lot of examples later, then you will start to see that what is the abnormal lesion, whether it's going to be appear bright or it's going to appear dark. Then it depends on the properties. Okay, I will just skip this slide first. We'll just go through some example. Okay, so we'll talk about what are the abnormal lesion that is going to be hyper intense or bright under be the T1 or T2. So we'll just focus T1 here first. Any metal, like we mentioned just now, any metal, it will appear bright. Okay, for example, this patient has a copper deposition. Most likely this patient has a Wilson disease because at the basal ganglia is a hyper intensity over the T1, which suggests that there's some metal deposition, and basal ganglia being the highest metabolic structure in the brain is going to be bright. Okay, because all the metal deposit there. And in choroid cyst, it's going to be bright under the T1 as well because it contains a lot of protein. So substance that contains, for example, metal, protein, or even iron, for example, bleed, can appear bright under the T1 view. And melanoma as well because of the melanin deposition. So these four things are usually things that we see, which is going to be bright under the T1. How about T2? T2, there's a lot of things that can be bright. For example, subacute bleed, neoplastic lesion or edema itself, abscess, as you can see here, or edema, and then hydrocephalus because periventricular transependymal flow towards the lateral ventricle. So you can see the bright periventricular lesion here. And inflammation like demyelination, MS, MMOSD, usually they will appear bright at the subcortical region. And then small vessel disease as well in the periventricular area, and chronic hematoma. I will discuss about the acute, chronic, acute, subacute, and chronic intracranial bleed later. But basically, these are all the common pathology that will appear bright. How we remember in a simple way is actually shine, shimmers. Okay, you can use this mnemonic, but you can just, based on your deduction, you can identify whether the structure is bright or dark. Shine, which means like subacute hematoma, and then H is about, I is about inflammation, and then edema, N is neoplastic, things like that. And then shimmer, for example, is like SH is a subacute hematoma, metal deposition, melanoma. R is the protein-rich structures. Okay, so how about any particular abnormal lesions that are going to be dark or hypo-intensity under the T1 and T2? T1 usually, if you see something dark which is not normal, it can only be a few things. It can either be a fluid or it can either be a chronic lesion. For example, in the MS, multiple sclerosis, in the O demyelinating plaques, is something we call as black holes. Okay, those are the O lesion. Okay, and then for T2, what are the abnormal lesions that's going to appear dark under the T2? So whatever things that is bright in T1 is going to be appear dark in T2. So similar if all those things that we have discussed in T1 is going to be dark under the T2, which is including the choroid cyst is going to be dark, and then the metal as well, as you can see, and then there's an acute bleed as well, you can see, and there's a flow void. Flow void is a flowing blood, and it will actually usually appears dark. Okay, so I will come to this important slide. Basically, this slide is more important for neurosurgical colleagues, but I think it's good for us to discuss because different phase of intracranial bleed will actually shown up differently under the MRI sequence based on T1 and T2 and based on the timing itself. In the acute bleed, which usually occurs in 1 to 3 days time, is the deposition of the deoxyhemoglobin. And in subacute bleed, usually is more to methemoglobin, and in chronic, it's usually about hemosiderin deposition. So in T1, in acute bleed, under the T1, most likely you cannot see anything. You can only see the surrounding edema, but it is iso intense. Okay, you cannot see anything. But under the T2, you will see dark. Okay, in the acute bleed. How about subacute? Subacute, you will see both are actually bright, hyper intense in T1 and T2. For chronic bleed, T1 is going to be dark. Like I say, any chronic lesion in is going to appear dark under the T1. Okay, so-called the black holes. Okay, and then T2 is going to be bright because of hemosiderin deposition. So based on that, if you look at a patient with a so-called previous history of intracranial bleeding, and you accidentally or for other indication you have done the MRI, you can actually know that whether this bleed is actually acute, subacute, or chronic. So I'll give you an example. So this is an MRI for a patient, and as you can see here, this is T1 and this is T2. So maybe I will just shout out anyone that can actually help me to answer this question. Maybe Vivian Tai, are you still around? Not around.
Hello, can you hear me?
Yeah, I can hear you.
So, from what you have described just now, this is like a right intraparenchymal subacute bleed.
Subacute. Okay.
Subacute bleed.
Okay, good.
Hello?
Why you say subacute? Hello, yes. Why you say this is subacute bleed?
Hello, because both T1 and T2 brights up the lesion brights out in both T1 and T2.
Yes, you are right. You are totally right. So this is actually very helpful for us, especially if we have opportunity to look back MRI, things like that. Sometimes we can actually see some things that actually quite interesting. Okay, so so I will just proceed. So you are right, Vivian Tai is a subacute hematoma. So the second last portion I'm going to focus under the approach is to look for the pattern. Okay, and different type of enhancement can actually give us different clue what are the things that is possible. So enhancement can be intra-axial or extra-axial. Extra-axial is the one that we mentioned just now, the dural tail. Okay, you can see here is because it doesn't involve the cortical tissue. So it will actually just at the lining of the near the skull, and then there is a dural tail. Okay, so the second type of enhancement, which is extra-axial, is the leptomeningeal enhancement, which is typically seen. It can be in the meningitis, be it bacteria or virus. It can also be some form of carcinomatosis. Okay, from the lung, from the cancer per se, malignant metastasis. And the third type of extra-axial enhancement is actually periventricular. So you can see that periventricular enhancement can suggest different things. For intra-axial, there's either ring enhancement, subcortical nodular enhancement, or mural enhancement. Okay, so this is the common example. For example, if you see dural tail, most likely it's the meningioma. And then if you see leptomeningeal, it can be cancer or it can be meningoencephalitis or meningitis. And then if you see periventricular, in which the primary CNS lymphoma actually likes to deposit at the periventricular region, but not always. It's just that it actually has a tendency to actually stays in the periventricular region. And then for the ring enhancement and the intra-axial, usually it will suggest, give us a few clues. For example, if it's a complete ring enhancement, usually it's abscess. And then toxoplasmosis also can be appears like that, primary CNS lymphoma as well. And then if it's like irregular structure, then you will need to suspect glioblastoma multiforme. Then subcorticular, it can be brain mets or acute demyelinating lesion. The mural nodule is a bit rare. Usually it's only found in the phenotypic astrocytoma. Okay, these are the few common examples of the enhancement. I'm going to give an example. So this is the T1 post-gado linear view of the patient. This is two different patients. The left here, you can see there's a lot of serpentine kind of leptomeningeal enhancement. And this, you usually found this in bacterial meningitis. Okay, as opposed to this, you can, as we discussed just now, if you look at the basal system, it shouldn't light up post-gado like this. And if it's like a lot of enhancement at the systems, you need to suspect that this is a leptomeningeal basal enhancement, which most likely the etiology is due to TB meningitis, because TB likes to deposit at the basal meninges. Okay, so now how about this lesion? So maybe I will just go to, I will just find one volunteer, maybe Benjamin. Benjamin, can you tell me what do you see? Hi, Benjamin.
Hello. Hi. Just a moment, please. Okay, hi. Can you hear me?
Yeah, I can hear.
Okay, I think from the appearance here on the MRI, what I can see is an area of hypodensity, and central to that is actually an area of a ring enhancing lesion on the MRI. So over here, I think differentials could possibly involve glioblastoma multiforme or possibly primary brain tumor. Other possibilities could also be a focus of infection or abscess as well.
Good. So the thing is, what sequence is this? What MRI sequence is this we are looking at? Hello, Benjamin?
Hello. Sorry, let me just test it.
Yeah. What sequence is this? As you look, I mean, although this is just a single one plane view, what sequence is this?
Right. I think this looks like a T1 sequence.
T1 with or without gadol?
This is with gadolinium.
Yes, this is gadolinium, because you can see the meninges here. It's a bit bright. You can see. So this is a ring enhancing intra-axial enhancement that Benjamin has correctly pointed out, and this is actually complete and well defined. So most likely patient, and there's also surrounding vasogenic edema which appears dark. Okay, and you confirm it with DWI and ADC. So in DWI, you can see that there's hyper intense, which means there is increase in the there's increase in terms of the sorry, that's not increase. If it's bright under the DWI, which means that the diffusion is actually restricted. And you confirm it with ADC, which is totally the opposite. There's no evidence of any abnormal shine through. So this is the true central diffusion restriction with a ring enhancing vision post-gadol with a surrounding vasogenic edema. So the most likely etiology, like you say, is brain abscess. Okay, it can also be GBM, glioblastoma multiforme, but usually GBM will look like this. Usually it's also ring enhancing, but usually it's irregular, and then usually inside is usually it's not fully iso intense. It can be iso to hyper or hypo intense, things like that, and usually it involves some midline structure appears in the middle. So, and for example, this structure actually involves the corpus callosum, and then it's also irregular. So this is GBM. Okay. So next, I think this one I will just okay, I will just name one person to answer. Okay, maybe I saw Zheguan. I saw Zheguan. I know she's on leave, but somehow she attended. So yeah, Zheguan, are you there? No.
Yeah.
No. Okay. Yeah. Can you look at this just a short history things and tell me what you are thinking?
I'm thinking of osmotic demyelination syndrome.
Yes, you are right. Okay, so in osmotic demyelination syndrome, do we need MRI?
Yeah, because I think you want to see the points, the changes there.
Yes. Yeah.
I cannot remember the change.
Okay. Yes, correct. Thank you, Zheguan. So as Zheguan correctly rightly point out, the older name for osmotic demyelination syndrome is actually known as central pontine myelinolysis. But this new term, this old term is no longer be used because sometimes the myelinolysis, the osmotic part is not only limited at the ponds. There's also extra pontine manifestation. So that's why we prefer the term osmotic demyelination syndrome. So based on this issue, we look at the MRI. Okay, as you can see here, this is a T1. Both of these are T1. Just like this axial and this sagittal. And you can see that it's a so-called trident shape. Okay, there's a three-pointed star like a Poseidon trident. And then you confirm that is T2, you can see that, okay, T2 is actually, you can see here, it's actually dark in the periphery and the center is actually bright, hyper intense. And the flare was actually almost like that. And you compare with the DWI sequence, which shows that there is the diffusion, there is a restricted diffusion because it appears bright in the periphery. You can see here, and bright in the periphery. So this trident shape, which appears hypo-intense in T1 and hyper-intense in T2, and with a diffusion restriction, is very suggestive of osmotic demyelination syndrome. Usually patient, as you can see in the history, patient GCS is actually quite poor. Subsequently, after rapid overcorrection of the sodium, in which the latest recommended guideline usually cannot go more than 6 to 8 millimole per liter per day. So this patient actually was corrected more than if you divide by 3, it's about 12 millimole per liter per day. So rapid overcorrection of sodium will actually cause persistently poor GCS because patient might be in comatose state, and some patient can have a seizure because of this. And then some also can have permanent deficit. Usually the prognosis is not to say very good, and then the management is mostly supportive. Okay, so I will just go to a few more scenarios. You can see that not many are, okay, oh, I saw Azim, okay. Oh, Azim, can you answer this question? Azim, are you there?
Hello.
Hello, yes.
Hel-
Can you describe the MRI brain that you saw?
Hello, can you hear me?
Yeah, yes, I can hear you.
Oh, okay. So 70 years old, newly diagnosed lung SCC, presented with altered mental state. So I think what we would want to rule out is, of course, brain metastases. On the image on the far left, which I believe is the T1 image, so there is hyper intensity. Sorry, no, it's a CT.
Yeah, it's a CT brain, right?
Yeah, sorry.
Yeah.
So there is increased density, hyper density lesion in the right frontal lobe, as well as there is surrounding vasogenic edema, sort of finger-like projections on the CT.
How about MRI?
So on the MRI, T2 image in the center, there is hyper intensity lesion there. Also very extensive with the midline shift and mass effect. And on T2 flare, can see quite a massive lesion there with I'm guessing also finger-like projections of
what does the finger-like
edema
projection mean?
Sorry?
What does the finger-like hyperintensity in flare mean?
I'm guessing edema, is it? No?
Yes. Yes. Okay. Good. Yeah. So you are. What is your diagnosis for this patient? If let's say you saw this patient. Hello, Ajim.
Hello, can you hear me?
Yes, can.
Oh, okay. Lung small cell carcinoma with brain metastases.
Yeah, with also vasogenic edema causing midline shift. Okay. So this is quite classical as compared to, remember what we talked about, chemotherapy demyelination versus tumor. If a tumor is going to be so huge and expensive, usually it will cause a lot of vasogenic edema and will definitely cause midline shift. As compared to the chemotherapy demyelination slide that I presented just now earlier, as you can see, the lesion is very big, but the midline shift is just minimal. Okay, so okay, this I think maybe I don't need volunteer for this. Everyone can see that this is a very clear spot diagnosis. There is subcortical lesion at it's a periventricular lesion, and in the sagittal view, okay, this is a flare sequence, and there's a subcortical over hyperintensity. So this is most likely dorsal finger and also periventricular hypertension. This is most likely to be multiple sclerosis, very typical for multiple sclerosis. So I think I will need one more volunteer. Maybe we will ask Kushna. Are you there? Kushna? Okay, now maybe Kushna is quite busy because she actually in charge of the acute cubicle. So how about Jason? Jason? Hello, can you unmute yourself, Jason? I couldn't get a response. Never mind. How about Vivian Tai again? Vivian? Hello, can you hear me, Vivian? Okay. Yeah, everyone seems to be having issue. Maybe we just proceed lah. So this is a 20 years old lady who is pregnant, 6 weeks, presented with headache and altered mental state. So the BP upon arrival to the emergency was 210, 110, and urine shows proteinuria. So very typical and very classical history. But sometimes we also get this when we cover referral from the WC. So this is the MRI shows. Based on this history, we are thinking of PrEP, okay? Because patient have a preeclampsia, and then the BP was also high, and patient have a headache as well as the fluctuating kind of GCS. So these are all the sequence of the MRI. The reason why I want to illustrate this case is, in MRI, usually after identify the abnormal lesion, we need to compare sequence by sequence. We cannot just look at one sequence because it's not going to be very helpful if we just look at only one. So this is a T. I will show here. This is T1. Just a different part. Okay. This is a ganglionic part, and this is the superior frontal parietal part. And then this T2, this T2 flare, and this TWI and ADC. So you can see in T1 there is a bit of not very sure, but there is a bit of hypo intensity seen in T1 at the occipital. Okay, more parietal, I would say, more to parietal cortex. Okay, and in T2 at the same level, you can see there is also hyperintensity. Okay, and in T2, after you attenuate the CSF out, you can see that T2 flare sequence indeed there's a hyperintensity. So when you look at this lesion, whether this is a diffusion limit restricted lesion or there's no diffusion restriction. We look at DWI and ADC. So DWI you cannot see anything, it's dark. Okay, dark meaning there's no restriction diffusion. Okay, and ADC true enough is bright, which confirm that the DWI is actually dark. So in conclusion, for this patient, is actually having a classical PrEP because there is a posterior hyperintensity in T2 and hypointensity in T1, and there is no diffusion restriction. Because in diffusion restriction, this can be shown. Sometimes in a patient like this, we are not sure whether this is PrEP or this is show. So we look at DWI and ADC. It show because of cytotoxic edema, DWI is going to appear bright instead of dark. Okay, I hope everyone remember what we have discussed earlier. So in PrEP, it's quite important because sometimes you get referral for this. I was in charge of therapy last week and I actually got a referral for PrEP as well, but it was an atypical PrEP because it actually involved a frontal lobe instead of just posterior. So in PrEP, finger feature is usually headache, seizure, a bit of blurring of vision, sometimes can have transient vision loss as well. And it's usually patient presented with acute hypertensive emergency or urgency. But the button feature is actually more to three things, whether it's because of the loss of the autoregulation of the brain tissue, or endothelial dysfunction, or even vessel constriction from the vessels. And then for the phenotype, usually the one that we discussed in the previous slide is a typical presentation of the PrEP. Then for atypical one, like I mentioned, the last week, the referral that I received is actually bifrontal. Okay, it's very atypical kind of presentation, but still can happen. Okay, and the cause is usually because of the acute hypertension, be it the postpartum eclampsia, preeclampsia, or acute GN. And then it also in condition like autoimmune condition, SLE, HUS, TTP, and then post-chemotherapy drug like cisplatin, calcineurin inhibitors, tacrolimus, cyclosporin, things like that. Sickle cell can also, because it actually causes endothelial dysfunction. And occasionally, a very bad sepsis can also have PrEP. So the MRI feature, like we mentioned, usually symmetrical subcortical hyperintensity, no mass effect, and there's no restriction diffusion. Compared to acute ischemic stroke, it's going to be cytotoxic edema. Okay, so maybe this is the last case that I'm going to ask anyone there. Maybe Vivian Tai, are you still there?
Yes, I'm here.
Yeah. Oh, okay. Okay, can you start case? Maybe there's a lot of interference there.
Hello.
Then yes.
Sorry, just one now. Yes, hello.
Yes.
45 years old male presented with progressive right-sided body weakness and recurrent seizures. He appears khaki sick.
Oh, But before that, what is your thought of this case scenario? I mean, the clue is patient is the male, gastric, and then got seizure and a bit of right-sided body weakness, right? So what would be your thought at this point of time? Maybe before you look at the scan.
I'm thinking of more of malignancy,
Okay.
with malignancy in the brain or brain mets.
Other than malignancy, can it be some form of infection?
Yes, if let's say it is a like TB infection.
Opportunistic infection, you mean? All the other common, yeah. Okay, so I think you're okay. Then we proceed with the MRI. So I know it's a bit busy here. Got T1, T2, got the 6 sequence that we discussed. Maybe you can just give a rough idea of what you are thinking after you look through this. Maybe you can start off with the T1 gadolinium, post-gadolinium view, because I think that's going to be very helpful.
Okay.
Do you see any enhancement under the T1 post-gadolinium?
Yes, there is an enhancement around there's a hypointense lesion at the middle, then there's a enhancement around the lesion, then outside it, another.
So maybe before, maybe we'll just pause on that. You say there's enhancement. Is it intra-axial or extra-axial?
Intra-axial.
Okay, intra-axial. Is this, what type of particular intra-axial enhancement pattern that you can appreciate? Is it like nodular? Is it like mural? Is it like ring?
Nodular.
More to ring, right? Because it appears like a ring. Yes. Yes. Okay. So how about you look at DWI and the ADC sequence? What can you appreciate from there? Is there a diffusion restriction?
For the DWI, there is only one small spot of a hyper intense, but the overall is rather iso intense.
Yeah, and then you can see ADC is actually bright, right? So corresponding to a bit dark over the DWI. So there is no diffusion restriction, right? So most likely all these are just vasogenic edema. Okay, so what might be your differential diagnosis at this point of time? If let's say you're suspecting malignancy and infection, like let's say I tell you this patient investigation was positive for RBD.
Would be like toxoplasmosis with
toxoplasmosis. Yes, if other than toxoplasmosis, the brain cancer, like you mentioned, any possibility, any other differential diagnosis other than toxoplasmosis?
Lymphoma, CNS lymphoma.
Yes, correct. So our top 2 differential diagnosis for this patient will be cerebral toxo or can be CNS lymphoma. Okay, because they sometimes can appear similar. Okay, so consequently, you found that toxoplasma IgG is actually very highly elevated. So this patient actually correctly, as Vivian correctly pointed out, is a cerebral toxoplasma with newly diagnosed RED. So I think I'm just going to go through very fast, and then we'll just put out everything because the time is actually quite short. So this patient with this MRI image we already discussed just now, hypointense in T1, and then you can see under the post T1 gado, there is enhancement, extra-axial enhancement, fulfilling more to dural tail. And then there's also a cleft, actually, but you cannot really see. So most likely this is meningioma. This is a dural tail sign. This patient, the history for this patient is real, but the MRI is not belongs to that patient because I don't want to take any real MRI images from our clinic or our ward because of the digital contracting that we need to sign. But the scenario is real. Okay, this is a 54-year-old Chinese male, have a history of recurrent fall and dizziness since 2017. He was actually treated as a cerebellar shock in Selayang Hospital. However, he was discharged with secondary stroke prevention, the medication. However, he was referred to our clinic because of persistent falls and dizziness. Was actually seen by our clinic. From our history, patient actually was able to ambulate walking stick in 2017. But in 2018, in 1 year time, patient require walking frame. And in 2019, patient subsequently was wheelchair dependent. So you can see there's a very significant functional progression for this patient. And in neurology, we like to use this as a wheelchair sign. Less than 5 years time, patient already wheelchair bound. And the ATR is actually semi-dependent. And this patient, when I think Dr. Tyler actually saw this case, if you remember. Yeah. So this patient, that time when we saw in clinic together with twin, he actually has a very significant cerebellar sign. And we immediately ordered the MRI and review back in 2 weeks time after the MRI, which shows something similar as the MRI in the slide here, which I think everyone should know because everyone attended twins CMEs on multiple systemic atrophy because of this hot cross band sign. So this is very specific sign for MSA. And for that patient actually has MSAC because of the cerebellar involvement, not so much of Parkinsonism. And this one, yeah, I did just going to go through. This is very cute. If you can appreciate the pattern, it's actually look like a panda. So in Wilson disease, here's something. If you manage to find that, is good. But most of the time, usually we hardly find any Wilson disease in our population. So giant panda sign, if you find this, then it's highly specific for Wilson disease. And how about this patient? This represents 3 different patients with the same diagnosis. And you can see here, this is the midbrain, looks atrophic, and appears as if like a bird, like a hummingbird. Right. And then this one, also the level of the midbrain looks as if there's a ear, and then there's a face here, looks like a Mickey Mouse. This one looks like a flower, like a morning glory. So with that, we know that most likely this patient is having a progressive supranuclear palsy, Parkinsonism, plus with all the classic features that we can detect in MRI. Okay, so this one is, I also see similar patient before we did MRI in clinic. I remember the patient actually have a larger lesion than this. She was very ataxic, less than 2 years time, persistently dizziness, every day also dizzy, cannot walk. And then when I assess the patient actually have difficulty to listen to me. So she actually have bilateral sensory neural hearing loss according to the Weber and Rini test in this side. But the hearing loss is actually more severe over the right side. And the cerebellar sign bilateral also present, but it's more severe over the right as well. So we ordered the MRI brain urgent, and turned out the patient had a similar kind of lesion. This is a CP angle, cerebral pontine angle, and this is a classical ice cream cone sign, which suggests that patient have a vestibular sonoma, because usually you can see here the tapering, the tip here extending from the actual IAM, internal acoustimeters, up to the CP angle. So this is very classic for vestibular sonoma. And this one, yeah, just want to save our time. So this one you can see, basically we need to identify what sequence we are looking at, okay? So this is, you can see gray matter appears gray and the white matter appears slightly darker. So you know that this is a T2, but you can see that there is CSF fluid here. So the CSF fluid was not attenuated. So this is just a T2, okay? T2 view. And in T2 view, you can see that the basal ganglia here appears dark, okay? As you can see, sorry. Oh, sorry, globus pallidus appears dark, okay? Yeah, sorry, thanks for that. Yeah, so as we discussed earlier, in T2, if it's in T1, any metal, any deposition will appear bright in T1, but will appear dark in T2. So this patient also have similar kind of hypo-intensity under the T2 and at the level of the globus pallidus. So this is very classic, looks like a face of the tiger. So this is so-called the eye of the tiger sign, which is diagnosis will be taken, okay? Phytogenic associated neurodegeneration. The old name for that is actually neurodegeneration of iron accumulation. So NBIA, but I think the new term has replaced the old term. So